Do we need a national organisation for the resistance to protocols? Because probably that's the biggest strain on all of our practices, particularly with a disjunct, where it doesn't make sense in patient care. It's just something that's measurable, so they're going to look at us and check on us.
Is that something in New Zealand that's a particular issue for GPs in New Zealand?
Oh yeah, absolutely. Though interestingly, the Ministry of Health are just looking at that because they're getting the message. And I was at a workshop where they're trying to look at meaningful measures and appropriate incentives, which might not be financial incentives. Moving away from the, what do you have, quaffs, don't you? Moving away from that model. I don't know if they're going to succeed, but they're showing a little bit of interest. We'll see. What do you think, Martin?
I don't share your optimism, Martin.
No, well...
I think that what the policies of New Zealand is that we prove that what Britain has proven 5 years before, we prove that it fails also in New Zealand.
Yeah.
And I think we're about to enter into proving that off is a bad idea, and
sure.
We'll prove that it fails in New Zealand as well, which is a tragedy, but maybe it's
Well, I'm not politically inclined. Cough it'd be a shame to throw cough out completely. It actually has made an enormous difference to healthcare in certain long-term conditions that were not getting the appropriate focus previously. But the problem with performance management is that sometimes it's not so much that the aspiration is wrong, it's the way it's measured doesn't chime with good clinical practice.
Yeah.
For instance, time-limited reviews don't work in planned care. Planned care, there's this tension between planned care and humane care. Not all humane care is planned and not all planned care is humane. And trying to get that message across is a real challenge. And I mentioned Twitter. Another way that I've survived is I've searched out in recent years anything to do with humane type workshops. So things like the Human Values for Healthcare Forum, ethics stuff, reading the ethics articles in the British Journal of General Practice, learning the language of philosophy of medicine has given me words and language which de-stresses me. So I found that having the language to express what we're struggling with is part of the way of dealing with the distress.
Thank you. Anyone in this area? Any skills that you put into practice, or something that you share, or an activity that you'd like to share with us?
Our country is very stressful, and we have no such Lithuania, and we have no such coffee breaks and so on. We, our skills more individuals. We cope with stress individually. We talk with our friends, GPs, about what we feel, and this is in an individual way, not an office.
And if you work in a group together in the same building?
We have no time for such, we think though that we have no time.
Is it possible that you might change?
We could change maybe this.
What might you do?
Well, for example, I work in practice, group practice. We have 8 family doctors. 4 family doctors in half day and 4 family doctors after that.
In the afternoon?
Yes.
Okay.
So we change. At the same time, it could be 4 or 3 doctors. But we are overloaded, and we try to manage all these new things, and so for talking it will be some kind, wasting time, because our patients are very, impatient. They want attention at this moment and not later. So it is difficult to find time during a job to speak and to change. But if a very critical case, we go to our colleague and talk at this moment.
After the critical
yes, after this moment we talk. If very difficult situation, for example, and we need to, we could talk with each other.
To get support?
Yes.
So you can factor a few moments in to do that?
Sorry?
If it's necessary, you can take a few minutes out
Yes,
of your...
yes, we interrupt our work and to
Yes.
go. Because
So
it
maybe
is-
you could extend that as a preventative measure as well, and maybe say, whatever, at 11 o'clock in the morning and
Yeah.
at 3:30 in the afternoon, we will stop for 3 minutes. And go to another room. Any other suggestions?
Part of that is, if I'm stopping at 11, right, and my
Yes.
colleague's finishing a patient at 11:07, other colleagues thought, I mean, staggering, right?
Yes.
Staggering a
You
patient.
can stagger, but you can text, and you can say, I'm free in 5 minutes, or 3 minutes if you want to
And
finish
just
up.
leave the patient, yeah.
And just finish at that patient, not leave them, finish at that patient. Excuse me while I go take my break.
I trust my patients in my room, actually.
So maybe do you work together in the same area?
Yes.
So maybe you could perhaps discuss this with your colleagues at home and maybe try to say, we must do something, otherwise, for example, do you take a break to have a cup of tea or?
Yes,
Yes.
we have such breaks.
So, then maybe build on that.
Thank you.
If anyone else would like to suggest something, please do.
I'd like to support this idea of yours or maybe work with an idea like that of making some sort of resistance against useless procedures and guidelines. Because now I've been working with quality and been leading this quality network for many years, and in the start it was sort of an engaging exercise for people who would like to improve general practice. And gradually it has been, making indicators, doing guidelines, trying to make people work out of these guidelines have been an expanding thing in many of the leading countries. And then now it seems to become a stress factor both for patients and for GPs, and some are even trying to make indicators of the non-measurable things like the doctor-patient relationship and patient-centeredness and things like that, which is really difficult to measure because I feel that that which is not measurable is not noted and is not acknowledged. So I think that the people who have started all this should also take this into consideration, because I think that in doing quality work of different sorts, I think that prioritizing the most important things there and not letting it overwhelm the other parts of medicine is also a very important aspect of quality. So I would advocate that there should be limits to how many indicators can you have in a setting, how many guidelines can you implement. I mean, there should be limits to this and a prioritizing.
Well, one of the options in this meeting I was at was suggested that each practice proposes its own quality measures. So define it for yourself. What do you value? What do you think is important for your community?
And it goes.
And following that puts the trust back to the practice.
And it goes hand in hand with research that says that these activities should be led by GPs, in order to, or by the people working there, in order to have maximum impact.
And the real danger is that in the measurement of quality, it has a negative effect on the delivery of quality. And that's what we're experiencing.
Measuring does not improve quality.
No.
It's data collection.
No, it has a negative effect. It deteriorates quality.
Yeah.
Self-defeating.
Yeah.